So yes, for our first speaker today, I'd like to introduce Dr. Fraser Henderson. Dr. Henderson is a board-certified neurological surgeon and fellowship-trained spine surgeon. He serves as clinical professor of neurosurgery at the University of Maryland School of Medicine. He is director of the Metropolitan Neurosurgery Group and has had a distinguished career spanning academic medicine, military service, and clinical innovation. His work focuses on cranio-cervical disorders, Chiari malformation, and complex spinal conditions, including those associated with Ehlers-Danlos Syndrome. And we know of what we learned already of Ehlers-Danlos Syndrome, that these can be very, very complex. So it takes a very brave and innovative mind to approach these with surgical precision. So please welcome Dr. Fraser Henderson.
I think it's appropriate that one of the best medical institutions in the world should be hosting a center for Ehlers-Danlos Syndrome. This is not a rare disorder. You know, we find that many of our friends' families have Ehlers-Danlos Syndrome through them, and they're all great people. So it's an honor to be here today. Let's see. And thank you for the invitation. What? Oh, you use someone?
Yeah.
This is not working? Okay.
Yeah.
What's that? I can just use this.
Very good.
I'd like to honor my mentors, the late John Jane, who is chairman here at University of Virginia, who spurred my interest in neurosurgery, Fano Perot, who is my professor and chairman for neurosurgery, and Professor Alan Crockett, lower right there, under whom I did a fellowship in cranio-cervical surgery in the early 90s in London at Queen Square. And we studied, amongst other things, connective tissue disorders and did a great deal of the early surgery on things like osteogenesis imperfecta and rheumatoid arthritis and other connective tissue disorders. But at that time, very little was known about Ehlers-Danlos Syndrome. But my interest was particularly spurred when Professor Crockett asked me to look at the neuropathology of 10 patients who had died as a result of the odontoid pressing on the brainstem, so-called basilar invagination. And he said, you're going to find ischemic disease, write it up and we'll move on. And we did the histopathology and found results that we didn't expect and opined that these were the result of mechanical deformation. And this finding has informed all of the work I've done in the last 30 years. And at the time, no one really believed it, but subsequently, many papers have demonstrated this to be the case. A few years ago, a number of department chairmen and I published this, the neurological and spinal manifestations of Ehlers-Danlos Syndrome, of which cranio-cervical instability is prominent. And that's what I'll be discussing today. Now, from the outset, I want to make the strong point that hypermobility at the cranio-cervical junction does not equate to instability, and that the radiological findings alone do not mean instability. The notion of instability should imply the presence of neurological instability or impending neurological instability. And I'll just mention that atlantoaxial instability is frequently accompanying cranio-cervical instability. So for those of you who are not neurosurgeons, do we have any non-neurosurgeons here? Okay, a few of you. So I'll go through a little basic anatomy. The clivus is that wedge piece of bone at the base of the skull. And at the base of the clivus is the basion. And then the C2 vertebra is shown here. It's also called the axis because the C1 ring spins or turns around the axis, and the top of the axis, the top of the C2 vertebra, is the odontoid process because it looks like a tooth. So neurosurgeons understand the standard post-traumatic findings of cranio-cervical instability, and that's well accepted. And these are things like an increased gap at the atlantocondylar junction, shown on the left, or between the cranium and the spine. Or on the lower right, you'll see rupture of some ligaments, the tectorial ligament. And on the upper right, you'll see a space between the anterior tubercle of C1 and the odontoid process. That's the atlantodental interval. And if that's more than 3 millimeters in adult, that represents atlantoaxial instability. But the important thing is that neurosurgeons are recognizing these findings because it's usually in the presence of an acute trauma. That patient will have just suffered a motor vehicle collision, and so they're looking for these ligamentous injuries. And if you don't suspect the trauma in the first place, you probably won't make the diagnosis. So you have to suspect the problem first, because a lot of these CT findings are unreliable or not present or not really visible. The radiological findings for cranio-cervical instability can be normal. You can have a normal looking MRI. In many of these cases, atlantoaxial instability is present at the same time. And it's very often due to the alar ligament, which is damaged. And in half of these cases, if you notice the red arrows on the right, the Bayesian axis interval is abnormal, and I'm going to show you what that is in a minute. So there are clues, but the important thing is to note that people look for these findings in the setting of an acute trauma. Well, now with EDS, most patients don't have an acute trauma, and so neurosurgeons aren't looking for the findings. On the far right, you'll see that dotted line, and that's the Bayesian axis interval, and that's very prolonged. That represents almost certainly a severe medullary kinking, and that patient will have severe findings. Now, 13 years ago, members of 17 institutions came together under the auspices of the Chiara Stringamalia Foundation, and we concurred that ventral brainstem compression in front of the brainstem or spinal cord, or kinking of the brainstem, or deformation of the brainstem over the odontoid was potentially harmful to the spinal cord and brainstem, and that this would be manifest as a cervical medullary syndrome. What is the cervical medullary syndrome? It is headache, suboccipital or neck pain, bulbar symptoms that refer to the brainstem, such as altered vision, nystagmus, altered hearing, dizziness, imbalance, vertigo, choking, dysarthria, difficulty speaking, dysphagia. And dysautonomia is very common. Abnormal autonomic nervous system function. Syncope, fainting or pre-syncope, almost fainting. Disordered sleep architecture, and then symptoms of myelopathy, which is spinal cord injury, weakness, clumsiness, spasticity, altered sensation, altered gait, even urinary urgency frequency. So they're old measures of basilar invagination, meaning compression of the brainstem from below, and that's the where the odontoid process, that tooth-like process, transgresses the McGregor's or Wackenheim's line. But these three new measures were felt to be significant in predicting cranio-cervical instability or basilar invagination. And they are the clival axial angle, Grab-Mapstone-Oakes measurement, and Harris measurement. And I'm going to go through those in a minute and show them to you. And these same metrics have been substantiated in a more recent publication by Marath, Locamp, and Failings, and the Journal of Neurosurgery. And Michael Failings used to be a critic of this work, but he's obviously come around. And so the clival axial angle is that shown between the clivus and the axis, as shown here on the left, and more than 150 degrees would be normal. And when that angle is less than 135, you're getting in the abnormal, potentially pathologic region. We did an extensive review on this, published it about 8 years ago. Now, the Grab-Oaks measurement is that perpendicular measurement shown in red from the dura to a line drawn from the basion to the posterior inferior C2. And if that's 9 millimeters or more, that represents potential ventral brainstem compression. I'm going to dwell more on the Harris measurement, and that's that measurement between the basion, the base of the clivus, and the posterior axial line. And you see that line on the right behind the axis, behind the odontoid. And when that is 12 millimeters or more, that's potentially pathological. Harris looked at 400 normals, and none of his normals had a BAI of more than 12 millimeters. And moreover, the distance from the basion to the top of the spine should always be less than 12 millimeters. 12 millimeters or more represents a separation of the spine from the skull, and that's potentially a deadly situation. So here again is the abnormal BAI shown on the left. It's very abnormal. And you'll note the illustrations on the right and how a dynamic flexion extension MRI or CT or sometimes X-ray can demonstrate changes in the BAI. So in flexion, the BAI is typically longer. And in extension, it can reduce to almost zero. So if you look in the MRIs in the lower right, you'll see the BAI goes from, in this case, about 12 millimeters to zero, which means there's 12 millimeters of translation. That means the cranium is sliding backward and forward about 12 millimeters. Well, if you don't have an upright flexion extension MRI, we have about 5 of them in Washington and Maryland, but you can do we use a pillow under the head for flexion, or a pillow under the shoulders for an extension. It's not as good, but it might suffice. And others have substantiated the notion that at the cranio-cervical junction, there should be no sliding of the skull on the spine. There should be no translation. It's a simple flexion extension movement. And when you have some authors say more than 1 millimeter, that's abnormal. Given that Ehlers-Danlos Syndrome has so much hypermobility, I go with 4 millimeters. More than 4 millimeters of translation would be pathological. Well, now, Atul Goel, one of the famous Indian neurosurgeons, says that the junction between the cranium and the spine, the atlantocondylar joint shown here on the left, is the most stable in the body. It's a ball and socket joint. And he says that the C1-2 joint is the most unstable. And that if there's a problem, he says, it's always going to be at the C1-2 joint. Well, I and I think many others disagree that cranio-cervical instability does exist at the atlantocondylar joint. And that notion is supported by this recent publication by Huang, where they looked at 80 normal controls, 63 patients with Chiari malformation, and 42 with Chiari malformation and basilar invagination. And they found that the normals shown on the left have a normal ball and socket joint and no instability, whereas the patients with Chiari and basilar invagination had a flattened joint that allowed the skull to slide back and forward. And they found this in 100% of cases. So in fact, patients with cranio-cervical instability often have a flattened atlantocondylar junction that is permissive of translation. So I said that the atlantoaxial Oh. Have you all been able to hear what I've... Okay. When you're looking for cranio-cervical instability, it's a good idea also to look for atlantoaxial instability. And so we're looking here at an axial view through C1, C2, and that red line represents where that cut would be. And this is a CT of someone looking to our right. And in yellow, that's the C1 ring, the facet joint. And in white is the C2. And you'll see that that facet joint has become uncovered. That's an unstable joint. And that's due to weakening or incompetence of the alar ligament shown there on white on the left. In the middle, that black is the alar ligament. In the far right, under that red arrow, you see an attenuated alar ligament. So that's incompetent. That's the basis for atlantoaxial instability. And you can get these, you can get an angular, the best way to define atlantoaxial instability in the EDS populations is by doing a rotational CT scan. And that involves laying the patient in the CT scan and tilting the head first to the right and the left and looking at the axial views of the C1 and C2. And you'll note here in the middle, the C1 ring rotates 85 degrees and the C2 rotates 40 degrees, so that angular displacement is 45 degrees. More than 41 degrees is potentially pathological. On the left, you can see that that C1 bone is almost subluxed off that C2, almost dislocated. And on the right, that 3D CT shows the facet joint there, that the joint has almost become dislocated. Now, Fielding and Hawkins said that if that joint is 80% uncovered, that's unstable subluxation. I go with 90% or more, as shown on the left here. And that view is supported in the literature in the Journal of Neurosurgery. Now, sometimes you don't pick it up on a rotational view, and you can do a digital dynamic X-ray, DMX, or an open mouth view with the lateral head tilt. And when that C1 ring slides sideways more than 1.6 millimeters, that's abnormal. I go with if that lateral slide shown by the red arrow is 4 millimeters or more, that would represent atlantoaxial instability. So it turns out that instability have low line.
Yeah, it has to be green to be on.
Fine. And or a Chiari-1 malformation. So some of the Chiari literature is wrapped up in this cranio-cervical instability diagnosis. And in fact, of Miller-Rat's 350 odd patients, 13% of them had Ehlers-Danlos Syndrome. So Chiari malformation often occurs, probably more often occurs in the Ehlers-Danlos Syndrome population. And in a study from Georgetown, one of my former residents, Santu, showed that of the failed Chiari malformation decompressions, 80% of them had Ehlers-Danlos Syndrome. So in Doug Brockmeyer's study of 100 odd patients, roughly 1/5 of them had to come back for fusions, and the risk factors for needing a fusion with Chiari included what's called a Chiari 1.5 and a kyphotic clival axial angle, which I showed you, of less than 125 degrees, or the presence of basilar invagination. And in the study by Kleekamp of patients of 45 patients who needed revision surgery for Chiari malformation, 1/5 of them were found to have signs of instability or basilar invagination. And so he emphasized the need for dynamic flexion extension views. So a few years ago, under the auspices of the Medical Commission of the National Health Service in Great Britain and the Bobby Jones Chiari Syringomyelia Foundation and the Ehlers-Danlos Society and Lady Trish Malloch Brown, we had a roundtable discussion and determined or achieved a consensus that dynamic imaging was necessary, that instability was characterized by radiological metrics that have now been established in the literature, that the diagnosis of cranio-cervical instability warrants neurosurgical evaluation, and that these findings with radiological findings should prompt consideration of fusion stabilization. We did publish that. So the indications that I use for cranio-cervical fusion include severe headache or neck pain, and I say 7/10 here. Sometimes if there's a lot of disability, there may be less neck pain, and so the 7/10 is not a hard and fast rule. The cervical medullary syndrome is extremely important in making this diagnosis, and those findings are critical to the diagnosis of cranio-cervical instability. And they should be backed up by neurological findings referable to the cranio-cervical junction. And I like at least 2 or more findings of cranio-cervical instability or atlantoaxial instability. A kyphotic clival-axial angle, grab oaks, finding of basilar invagination, Chiari, or obstruction of CSF flow after they've been maximally treated and that they understand that surgery is the last resort. Now, I'll mention that of patients treated non-operatively, they can develop severe pain, restricted movement, signs of myelopathy, respiratory failure, vertebral artery dissection, quadriplegia, and even death. So non-operative management is not optimal. We published a series of patients who had cranio-cervical instability and then fusion stabilization, mostly women. Some of these patients have abnormalities of the vertebral arteries that should be looked for. And many of the patients, the majority, have a very high and medial vertebral artery, which makes placement of the screws potentially treacherous. We have established a methodology where we achieve good screw placement by the grace of God. Always, and I've not had a vertebral artery injury in 10 years. I haven't had any neurological strokes or any bad problems actually in my practice. But with a good methodology, these screws can be safely placed reliably at C1 and C2. We use intraoperative fluoroscopy and a CT scan when needed to confirm good placement. Now, the C2 nerve can be compressed by the posterior ring of C1 and the lamina of C2, causing occipital neuralgia. So we routinely take that nerve now to preempt the development of occipital neuralgia. Intraoperatively, we perform reduction to correctly align the cranium on the spine. So we're looking at the clival-axial angle. We want to get that ideally toward 160 degrees, but certainly more than 140. We want the mandible axial interval, that's between the mandible and the axis shown by the blue line. If that's less than 10, that can cause dysphagia, or if it's more than 24, that can cause dysphagia, difficulty swallowing. So, and we also measure the gaze angle because we don't want someone stargazing or looking at the floor. Our fusion rate has been very good. We use this a device that I developed 20 years ago that incorporates the bone graft. It's low profile, smooth, and it's very strong, shown in the lower left, upper right on the 3D CT. And we get a good mass of bone there, and it generally fuses very well. The results of our studies showed a good reduction of kyphosis, elimination of the ventral brainstem compression, and 94% of patients would have do the surgery again. 6% would not. A number of patients, we saw a significant improvement in vertigo, dizziness, headache, neck pain, decreased use of pain meds, decreased or elimination of syncope and pre-syncope, nausea, weakness, and fatigue, memory, concentration, visual changes, and dysautonomia is substantially reduced. The abnormal autonomic function is dysautonomia. When we correct the cranio-cervical junction, that gets much better. Orthostatic symptoms, memory, all improved. Now, of these 53 patients, we reported over 50 comorbid conditions, and the average patient in that study had 6 comorbid conditions. So in addition to correcting the cranio-cervical issues, the mast cell and these other issues need to be addressed. We didn't have any intraoperative complications. There are 4 wound dehiscences. One of those may have had an infection. We've now reduced wound dehiscence to about 2%. Range of motion is not an issue. There's so many levels of movement. It's extraordinarily rare that a patient will complain about loss of range of motion. And adjacent segment failure is a more complex issue. We never see C2-3 instability, but most patients who come in with a cranio-cervical instability have hypermobility at the mid-cervical level. And early on, I found that we were doing about 40% of these patients would come back for a mid-cervical fusion. Now we've got that number down to about 20% by encouraging patients to adopt excellent posture and avoid unnecessary neck movement and certainly, flexion, looking down at cell phones and computers. And when they do that, the number of patients needing lower cervical surgery is dropped to a minimum. So now the number of papers that discuss these metrics and the surgical results are many, and there should be no question about the validity of the diagnosis and the treatment. It works. I think those of us who do the surgery have found it's one of the most gratifying surgeries in what we do. What's the underlying pathophysiology? Basically, we're dealing with neuropathic symptoms. We're not dealing with a normal nervous system. We're dealing with a nervous system that has been deformed, stretched, injured, and now we're seeing the neuropathic symptoms, the abnormal responses to normal movements. And not just in terms of pain, but all forms of sensation. I discussed the early work we did, and then 20 years ago now, Ed Benzel and I published how stretch and deformation of the brainstem caused this cervical myelopathy. So the notion of mechanical deformity of the central nervous system causing neurological findings is well established. And those findings have been consolidated with electron micrography by Pavlicek a few years after my study. And he showed that stretching and deformity of the nervous system causes clumping and loss of the neurofilaments and formation of these axon retraction balls, similar to what we see in the brain following high-speed injuries. And Satman showed if you stretch a mouse optic nerve just 20%, within a few days, you find these axon retraction balls. This is the histological substrate of traction. Wolf showed if you stretch nerves leads to the pathological influx of calcium causing neural injury. Arundine showed that stretching of nerves causes apoptosis or cell death. And we've discussed how twisting of the brainstem, especially at C1-2, causes this stretch and mechanical deformation of the brainstem, causing those neuropathic symptoms. 20 years ago, we patented a computer program to predict mathematically the stresses in the brainstem. And we correlated these clinically, preoperatively, and postoperatively, and showed that reduction of the stress correlated with improvement of symptoms. And this has been validated more recently in the literature. And the dysautonomia, these fibers staining green in the picture represent sympathetic fibers in a rodent. And so rotation and twisting of the brainstem causes dysautonomia, we feel, primarily through disruption, injury to those fibers. And it's well established that rotation of the neck causes attenuation and even obstruction of the vertebral artery. And especially when you have asymmetric arteries, these can predispose to neurological symptoms or even stroke-like findings. So in conclusion, severe headache, neck pain, and symptoms of the cervical medullary syndrome, especially weakness, lower cranial nerve dysfunction, and long tract findings like hyperreflexia, should prompt consideration of cranio-cervical instability. The diagnosis is facilitated by flexion extension imaging. The horizontal Harris measurement is particularly useful. Appropriate reduction and fusion stabilization is associated in most cases with a significant improvement of neurologic symptoms. And we need to look more into the pathophysiology and especially the epidemiology and natural history of these disorders. So thank you for your attention. I'd like to acknowledge my colleagues, Robert Rosenbaum, Claire Francomano, Miles Kobe, Peter Rowe, the late Rodney Graham, Ed Benzel, the late Robert Gerwin, Mark Alexander, Kelly Tuckman, Ed Maitland, and Professor Alan Crockett. Thank you for your attention.
Yeah. So we do have time for questions. Yeah, first here. Yeah, good. That's great. Sarah.
Hey.
Obviously, because you framed me, I agree with the need for these surgeries and how to evaluate them. All right. Hi. For those at home, this is Sarah Cohen-Solomon, new to UVA, but not new to Dr. Henderson. We've shared many patients together who've benefited from his care. But as, of course, he and I have discussed before, there is a lot of difficulty getting this care to people who need it across the country and across the world. And I realize that is a very long subject for another day, but briefly, what can we do to make that better for the patients who need it? As briefly as you can.
You mean, how can we increase the number of people doing the surgery?
Well, how can we improve access to this care for people who need it? How can we get other neurosurgeons interested in performing it and improve care for everyone as a result, hopefully?
Yeah, well, we've been trying to do that. I think setting up this center is really terrific. I'd be happy to come down and give more lectures and happy to train people if they want to come and visit. I offered to go up to Canada. We did many lectures up in Canada, and but new things take a long time. I mean, remember that doctors were still not washing their hands in the Civil War. They had been looking at microbes under the microscope as early as 1600. 250 years later, they're still not washing their hands. Okay, so there's something wrong with the medical profession that we're so slow to adopt new thinking. That's a real problem getting access to, but I've been trying my best to promote it. I know Doug Brockmeyer is setting up a center out in Utah, which would be fantastic. And we have some people in Europe doing this surgery now. Sorry to see Sunil Patel develop some medical issues recently, but hopefully we can get that program going in South Carolina. But that doesn't answer your question, but maybe we can discuss that some other time. Yeah. Yeah.
And I had surgery. It saved my life. I had gone to the point where it's on. I had gotten to the point where I was just circling the drain. I think a lot of us live with cervical instability, and we have to spread the word of what it is and what it means. Dysautonomia is there's a lot of symptoms of dysautonomia that you could be living with and not know that it's the cervical instability. Anyways, access to care, I think insurance. I had to pay out of pocket. It is almost the cure of surgery is not available to the masses, even if you have the diagnosis. Insurance, and I forgot my other one. I actually suffered some brain damage from intracranial hypertension that I had before the surgery. So
yeah, insurance companies are very difficult to deal with these days, and I know one group of insurance companies never paid me for 1.5 years on my patients. Yeah, they can delay diagnoses. It's a real problem.
I have a quick question. For somebody who has cervical spine issues, let's say from a previous injury and has EDS, but is not a candidate for any type of surgery due to multiple severe metal allergies, how does that get handled?
Yeah, actually, that's fortunately a rare problem.
It must be the person that.
Yeah. So it's lucky that you don't need surgery. I
was actually told by 2 neurosurgeons that I should have.
That you should, okay.
Surgery.
And you have a titanium allergy?
Actually, it's technically not titanium. It's the titanium alloys. It's nickel, chrome, niobium, vanadium, and gold are the known ones.
Yeah.
So it kind of, I was told no.
Yeah.
And I did have temporary pins for a broken bone. Basically, they got shot out by my body within a week.
Right. Yeah.
So.
Well, I suppose there is the potential to use methyl methacrylate, and without methyl methacrylate, bone cement.
Oh, okay.
Yeah, and so there'd be ways, maybe ways around this. Yeah, are you what?
Acrylate allergy. I'm allergic to the methyl acrylate family.
And you're out of luck.
Okay. That's what I wanted to know.
But
I mean, basically, I'm just stuck with nonsense.
But there could be ways of doing a bracing and intermittent bracing and things like that. Okay. And so,
thank you.
Yeah.
Anyway, the question. Yeah. Can you repeat the question?
Yeah. What's my take on compression of the jugular veins? And that's the real problem. First off, it's most patients that I see have some degree of jugular vein compression, and large studies have shown that probably at least a third of studies of angiograms of the neck, at least a third show compression of the jugular veins. compression of the jugular vein does not mean you have symptoms from that, because over time, the brain finds other ways or the other pathways for the egress of venous blood. And so the first thing, you have to determine whether that compression is causing your symptoms, and that can be a little bit difficult. But if you have a severe compression of the jugular vein and you have findings of intracranial hypertension, meaning a pressure inside your head, it may be the neuro-ophthalmologic findings, it would be worthwhile getting a lumbar puncture to see if you have increased, raised CSF pressure, and more than 20 or 25 centimeters of water pressure is considered intracranial hypertension. Then you have an option of either drilling down the end of the C1 transverse process, or removing the styloid ligament to decompress the vein. Or in some cases, you can put a stent on the inside of the vein to maintain the open caliber. But it is a problem. It's not, you can't just look at a single picture and say, I've got jugular vein compression, I need treatment. It's more complex, and I would probably recommend getting an angiogram, and they look for what's called a pressure gradient. You'd want to see a high pressure above the stenosis and a low pressure below the stenosis to know that that region of compression is clinically significant. Does that answer your question? I would fix the stability first, because we know we know from hundreds of cases that the result of fixing that gives significant improvement. We don't have that kind of validation of the decompression of the jugular veins. So I would, my inclination would be to do the cranio-cervical fusion first.
Question.
And the last part of your question was? Yeah. Well, when we started, how long does it take from symptom onset to diagnosis, and how often do we see dismissal of symptoms? And when we were treating these patients 15 years ago, no one knew anything about Ehlers-Danlos Syndrome. And it took at least 10 years for people from symptom onset to diagnosis. 10 years was the average. And when we found, if we'd hear of a physical therapist or a doctor who knew something about Ehlers-Danlos Syndrome, we'd write their name down and say, great, there's one more person in the United States. Now the knowledge and understanding of EDS has increased amazingly, so that most people have heard of it now, and we're making great progress. And so I would imagine that time to diagnosis is down to 3 or 4 years. The internet has been a great help in self-diagnosis as well. Yeah.
So this question might not be appropriate for a surgeon, but I'm going to ask it anyways, especially for a patient who is not a surgical candidate. Your thoughts on prolotherapy and stem cell therapy?
Yeah, I think that for mild cases, but lentoaxial instability that the stem cell therapy might be effective if there's not a disruption of the alar ligament, but simply needs to be strengthened. I suspect that works. So we don't have any published information on that, but I know Chris Santeno is doing pretty good work out there. But it would be good if we had a publication. I think prolotherapy and stem cell therapy is very useful, especially for below C2, and much preferable if you can treat instability with that than with a surgery. And does that answer your questions?
Thank you.
One last question. Yeah.
Sounds like a very serious type of surgery. How does one find a neurosurgeon who's competent to diagnose and treat? Or do I just wait for you?
Yeah. The question is, how does one find a competent neurosurgeon? I think as the interest in EDS grows, you'll find a lot of competent neurosurgeons. Right now, they're just not many of us have. I've been dealing with these issues for 30 years, so most neurosurgeons haven't really thought about them much. They're certainly competent, and when they decide that they want to get involved, then they'll be able to take care of you. Yeah. Yeah. Okay. All right. Thank you very much.
Thank you, Dr.